So we thought we would convene this discussion today because of the specific challenge that MDR and XDR-TB present both to global TB control and obviously, especially in countries with high HIV prevalence, the threat of drug-resistant TB to TB control is very serious and needs urgent action and urgent measures. But MDR and XDR-TB also present a significant challenge to human rights and individual liberties. And so today we'd like to discuss critical questions about the appropriate balance between civil rights, individual rights and liberties, and public health. So here we are with 490,000 new cases of MDR, of drug-resistant TB worldwide every year, and with a prevalence that's estimated to be at least 3 times that much worldwide. Of these cases, of these 490,000 new cases of drug-resistant TB every year, the proportion of XDR-TB cases is not known, but by some estimations it may be 7% or maybe higher. And as you know, of course, both MDR and XDR-TB are very hard to treat, XDR-TB more so, and in the case of XDR-TB, we have very high mortality rates in cases where people are also infected with HIV. And so in some countries, we find that governments are implementing measures such as routine and prolonged detentions for the duration of the treatment of drug-resistant TB. And in South Africa in particular, we have cases of incarcerations behind barbed wire of drug-resistant patients. In some cases with no treatment being offered to these individuals. In many of these settings, there's no proper infection control, and health workers are also at serious danger of infection. So clearly, drug-resistant TB is changing the landscape for human rights in the context of a public health response, and we need to figure out what we're going to do to deal with this in a way that balances both human rights and public health. In the last year, we've had stories of very striking cases coming out of South Africa in particular of drug-resistant TB patients that have made the news. And one such case this year was the case of Mr. Sibanda, a man from Zimbabwe who was living in Botswana with his family and who was diagnosed with multiple drug-resistant TB. He was then incarcerated, arrested and incarcerated, and then he faced deportation with his family back to Zimbabwe. So that's when the case became known to the public.
The patient is being painted as the criminal when in fact those who are doing this, who are implementing these measures aren't taking sufficient steps to ensure the infection control that they state as being the primary objective for such harsh measures. So this man was in prison. The guards didn't have masks to protect them. He obviously wasn't wearing a mask either. And he wasn't being given access to treatment, although at this stage he had made it clear that as he was very sick, he was willing to go back on treatment. At this point, the Botswana Network of Ethics, Law and HIV/AIDS, we worked with them to put together a court case, an urgent action to grant him access to treatment. This was granted, and following that, his appeal for deportation was going to be heard. But before this appeal could be heard, Mr. Sibanda made the decision to withdraw it because of the socioeconomic challenges that he was going to be facing during the period of isolation that he would be compelled to undergo in order to receive the DR-TB treatment. He was going to have to be in isolation for the full duration of treatment because he was perceived to be a risk for non-adherence given his previous treatment interruption. So it wasn't about him being kept in hospital to prevent the spread of infection, but being kept in hospital for the full 24 months of treatment because he hadn't adhered in the past without really addressing and getting to the heart of the reasons why he hadn't adhered. He had a family in Botswana whom he wouldn't have been able to support, so he made the decision that he'd rather go back to Zimbabwe, travel with them, be amongst family and relatives, and probably not be able to access the treatment that he needed, as opposed to staying in Botswana, receiving treatment and watching his family suffer because they didn't have the socioeconomic support that they needed, which is another major area of concern that we've also seen in South Africa, where patients are kept in isolation for long periods of time to receive treatment, and no measures are being taken to ensure socioeconomic support for themselves and for their families during this time. Of course, this, as we've seen very clearly in Mr. Sibanda's case, is a major deterrent to seeking care and treatment. People need to be able to survive, they need to be able to eat, and that's going to always be the primary concern. And finally, the other thing that comes out quite strikingly from this is accountability, or the lack thereof. In all of this time when Mr. Sibanda was receiving such harsh treatment from the government for not having adhered to the treatment, we didn't see anything being done about the clinicians who had supervised this case for 3 months when he was reporting daily to receive MDR-TB treatment with one of the most important drugs from his regimen being left out. If we're really, if these sorts of measures are really about urgency and about controlling TB, then we need to see that urgency being applied in all directions, not just towards the patient. And I think this is a classic example of the sort of hysteria that you're talking about, which isn't really allowing us to have a comprehensive and rational response.
What's frightening about this is that the patient is to be kept in isolation, and there seems to be no other remedy for what's going to happen to their family, loss of job in the community, et cetera, et cetera. That's one piece of it. The second piece of it is that this doesn't have to actually happen. Most MDR-TB patients convert in the second month or the third month. They become smear negative. They're not even infectious. So they don't actually have to be locked up for 18 months or 24 months. They don't even need to be locked up for the 3 months. That's the third piece of it, is we have models of care that have been phenomenally successful where patients are treated in the community for the entire duration of treatment.
If you're really going to decide that the most effective approach is isolation, you have to think through the consequences of that in terms of the number of people affected. You started this discussion by talking about 490,000 people. That's a huge investment and a huge cost to imagine creating an isolation system that would house that many new people annually who have MDR-TB. The likelihood of someone with MDR-TB winding up in isolation is not even, regardless of the patient. It's highly uneven. And what are the factors that lead to someone being put in isolation whereas someone else isn't? And what are the specific policies and requirements that discriminate against people in that regard? For example, individuals who are receiving treatment from traditional practitioners or the private sector physicians don't end up in isolation. From a public health perspective, that doesn't make a whole lot of sense. And from a human rights perspective, that's clearly inequitable. And the fact is, your human rights are not abrogated if you have a disease like tuberculosis. There are ways in which you might have restrictions placed upon you that are consistent with ensuring protection of public health and human rights. But it's not one versus the other. It's really understanding how they relate to each other.
The importance of respecting, the patients are the first consideration, and that if, for whatever reason, once access has been provided, once everything has been put in place by an ideal, good program, there is a patient that, for whatever reason, does not understand, after having been counseled, supported, informed, that he or she is contagious to others with a potentially lethal disease, which is XDR-TB specifically, but I would actually expand it to the whole concept of tuberculosis when it is, for instance, in communities highly affected by HIV, then only as a final, as you mentioned already, only as a final type of step, then the potential isolation of the patient on a compulsory basis should be in a way considered. But that should be done, and that was very clear in the statement, according to the Syracuse principles that we have mentioned already. So that position was quite clear. So WHO has never supported any position that would be contrary to this basic human right type of approach and in a way patient-centered approach to TB control. But the vast majority of African countries have no capacity whatsoever to detect cases of MDR-TB. They simply don't have central laboratories that work, and if they have central laboratories, they're not equipped to do the basic drug susceptibility testing, which is the basic elementary thing, not that it's not complex, because with the tools we have today, it is relatively complex, it takes several weeks and so on, but this is what needs to be done for an African continent that is trying to really face an epidemic like this one. We have been trying to mobilize as much as possible. Now there is the Global Laboratory Initiative that has been launched exactly to do that type of work, to push countries that have been delaying for decades, the establishment of proper laboratories, push countries to really think carefully about that, to apply to the mechanisms that give money to Africa today, such as the Global Fund, as an example, or UNITAID, which is another example, to apply to this mechanism in such a way that the laboratories can be put in place as a starting point. So there is now tremendous pressure about that. There is mobilization of money from Global Fund to do things. Far from sufficient, because countries have not yet understood that laboratory issues are many countries, I'm not saying countries, but many countries have not yet understood that the laboratory issue is a major one and is probably the biggest impediment we have today for proper and prompt diagnosis of TB and specifically of MDR-TB. Without a good lab, you don't diagnose MDR-TB. MDR-TB does not exist unless you have a laboratory. You cannot see it from a chest X-ray, and obviously you cannot see it just looking at the sputum. So this is a top priority of everyone in the world, and the response will have to come in a way from the countries, supported financially with technical assistance and so on, to put in place laboratories of this kind. And there are beautiful examples that this type of thing can be done, and can be done in less than a year. Salman knows it all, and I see my friends from Lesotho here. That has been done in less than a year in a country like Lesotho that started from almost nothing. If countries are not prepared or have no money to do the job, in the case of Lesotho, it was solved thanks to George Soros that came, and we had even discussion with George Soros personally on this type of issues, mobilizing $2 or $3 million to help, in that case, Lesotho. That's what WHO can do. But don't expect that WHO can go and change the policy of South Africa overnight. That has not happened, unfortunately, with HIV for a decade.
We've been fortunate to be able to implement MDR-TB care in a number of settings. Back in 1995 and 1996, we started treating, Partners in Health started treating in the northern cone of Lima, Peru. And for most of you that know Lima, it's a really, really poor setting. Very little infrastructure, but there are clinics, there are X-ray facilities, but basically people went house to house and treated patients. There was not a lot of hospital backup. The cure rates initially were about 80%. Now that it's nationwide in Peru, it's between 65 and 70%. People were not incarcerated. People were enrolled in the program. They were treated in the community. It actually required training community health workers and training them in a very sophisticated way so that they could deliver, so they could basically be an extension of the clinic in the community, be a referral arm. And it seemed to work, and we didn't have to resort to these last resorts. Mm-hmm. Now, there's always a handful of patients, there's 2 or 3 or 10 or 20. I think Tim Holtz was telling me at lunch that in the United States there's 20 or 15 patients that require incarceration for short periods because they refuse to take their care. But it's a handful. If you provide care, people take the care generally. And I think if you overcome the structural barriers to care, whether it be transport, acute malnutrition, etc., you can do it. At first, everyone told us, oh my God, this is a boutique project. You're doing it in Peru, Partners in Health, Paul Farmer, you guys are driven, nobody else can do this, blah, blah, blah.
Yeah,
fine.
That's often what I hear. Is it scalable? Maybe it's the Cadillac model,
Then we did it in Russia.
Okay.
And it happened in Russia. Paul was not there very much. It involved Russian staff, Russian people, Russian doctors, Russian buildings, Russian buses, everything, and it worked. It's not perfect. It's better than most other regions of Russia, but it works. It's happened in Lesotho, as you mentioned. Again, a country with very little infrastructure, a program that is run by all African staff, mostly in-country staff, one consultant from Boston that goes back and forth for about 2 weeks every 2 months, an external laboratory consultant, and it works. I'm seeing here Dr. Rafael in the crowd. I just was in Azerbaijan. They have a prison system where they are treating MDR-TB in the prison. It's like a model for human rights. They're giving the patients chocolates every day. I mean, they have grounds to walk in with trees, and they have negative pressure rooms. So I think that if you want to do it, as Mario says, if you want to do it, and you put the resources to it, and you have a political commitment to do it, you can do it.
I wanted to add, though, that even in contexts where we have PEPFAR and we have resources, we still don't always have government commitment and political will and a recognition that HIV causes AIDS in certain places. Right. That's true. So a critical component to add to that, I think, is the work that Arasa is doing and that Paul is doing, and groups like Human Rights Watch to sort of keep pressure on governments to consider not just delivery of care, but the respect for human rights and how there has to be accountability for the programs that are put in place.
The fact is that countries themselves are also failing to take these very possible actions to address this epidemic. And we do need that sort of advocacy, but something I think that we also need from people who are making these policies and these guidelines and who are engaging with our governments at high-level meetings to discuss these sorts of things, to apparently create awareness on these recommendations, is to start creating that link between what you're doing and what we're doing.
If you look at the history of the HIV movement, the activists were ahead of every major initiative and innovating in prevention and innovating in treatment, treatment literacy, all of these ways in which the rest of us have played catch-up to try and adapt these approaches and really move them forward. And for the types of populations we're talking about in TB, and for what is needed and the scale of what is needed, there's no way that this can be done without that kind of activism.
Thank you. I think this conversation highlighted the fact that it is possible to balance human rights and public health, and in particular that we need to make an urgent effort to communicate the value of community-based healthcare models in drug-resistant TB care. We need to make the human rights argument, we need to make the public health arguments, we may need to make the cost-effectiveness arguments much more vigorously than we have. And we also need, as donors in particular, I take this lesson that we need to continue to support grassroots activism very strongly, but also keep encouraging and pushing the political will to develop at all levels, bearing in mind the different strategies that are needed for each context. So lots of work to do, but at least we have some solutions going forward that will respect human rights and enhance public health. Thank you very much.